Great. Welcome, everyone, to our webinar this morning. I'd like to begin by acknowledging that the land on which we're gathering today here in Kelowna at UBC Okanagan is the traditional unceded territory of the Syilx Okanagan Nation and their peoples. I also recognize that many of you are joining both from near and far, and I also want to acknowledge the traditional owners past and present of all those lands as well. So my name is Joan Batorf. I'm director of the Institute for Healthy Living and Chronic Disease Prevention here at UBC's Okanagan campus in Kelowna. And I'm delighted to welcome you here for this webinar that we are co-hosting with the North Okanagan Hospice Society and our colleagues at the Canadian Association of Psychosocial Oncology. We will invite our speakers to present this morning, but I also encourage you to type any questions or comments that you might have in the chat box, either during the presentation or at the end. And our speakers would be delighted to answer those questions and engage in conversation with you. So before we begin, though, I'd like to introduce Clara Dick, who's the Education and Resource Leader at the North Okanagan Hospice Society, to introduce our speakers. Clara.
Thanks, Joan. North Okanagan Hospice Society is so pleased to have an ongoing relationship with UBC Okanagan Institute for Healthy Living and Chronic Disease Prevention. It's our pleasure to introduce Dr. David Kenneth Wright. He is a registered nurse with a specialty in hospice palliative care. He's also Associate Professor, School of Nursing, University of Ottawa, Academic Lead, Palliative Care and Nursing Ethics Hub, Center for Research on Health and Nursing, and Director at Large Research, Canadian Hospice Palliative Care Nursing Group. As well, it's our pleasure to introduce Dr. Kim Mcmillan. She also is a registered nurse with her specialty in hospice palliative care. She's the Assistant Professor, School of Nursing, University of Ottawa, Academic Mentor, Palliative Care and Nursing Ethics Hub, Center for Research on Health and Nursing. Dr. Wright and Dr. Mcmillan will be presenting for us today, Relational Practice and Pandemic Restrictions, a qualitative study of palliative care nursing. I'll turn it over to you two.
Thank you so much, Clara, for that introduction. I just wanted to, thank all of the organizers for having us here today and give a very quick shout out. You mentioned in the intro the Canadian Hospice Palliative Care Nursing Group. As of this week, we are launching the Canadian Palliative Care Nursing Association, which is super exciting. And if anybody on the call today is interested in that, please contact us. So today, I'm just going to give you a little bit of an outline of what we want to achieve today. And how we're going to spend the next hour together. I am going to basically give a bit of background and suggest that relational practice is an ethical foundation of palliative care. I'm then going to present a brief overview of our study methodology, introduce you to some of the nurses that we've spoken to and the stories that we've heard. And then I'm going to hand off to Kim, who is going to springboard from those stories and present a thematic analysis around two salient ethical concerns, namely around personal protective equipment and visitor restrictions. And then she will offer a closing reflection. So typically, to orient you to a research project, I would at this stage present a background in the form of a literature review. But the thing about COVID-19 is that it presents a somewhat unique research context. Literally everyone, everywhere, is in some way currently living through this phenomenon. And so obviously we've seen a ton of attention in various media dissecting different aspects of the pandemic. So I want to take a moment to highlight two. The first, pictured here on the left, was published this month and concerns the way that COVID-19 affects death and grief. In this article, an American physician writes about how COVID-19 has warped how we die. He writes about the horrific moral calculus of pitting the desires of dying patients and their families to be together against a duty to minimize viral spread. He suggests that acts of compassion and mercy, such as allowing family members to see dying loved ones through windows, would in normal times be indistinguishable from cruelty. But these are not normal times. Now, this author does not offer an ethical evaluation on the separation of patients and families at the end of life, but concludes with an acknowledgement of the sheer magnitude of grief that is being created by such separation. So in his words, while the dead cannot suffer anymore, their loved ones will continue to grapple with their losses long after COVID-19 has settled into the pages of history. The second article, pictured here on the right, was published much earlier in the pandemic. So this came out in April. And here, Franco Carnevale, who is a nursing ethics scholar from McGill, argues that separating patients and families in hospitals and long-term care has much more serious ethical consequences than sadness and loneliness. Although to be clear, those matter also. But really, patients depend on their families for their safety. Families act as important advocates for patients who reside in healthcare institutions. They help them to interpret medical information and to make decisions that are in their own best interest. He suggests also that even the language of visitor is problematic because it masks the ethical significance that these people bring to the healthcare encounter. So in his words, when patients are barred from access to trusted family members, their vulnerability is dangerously amplified. And indeed, current research confirms this. So I, for example, can highlight one study that is currently being conducted by two social work researchers, Kathy Cortez-Miller and Susan Cadell, about how families are grieving deaths that have occurred since the pandemic began. They are finding that these grievers that they're interviewing strongly resist the language of visitor. In fact, one of their interviewees whose child was dying in an institution right as visit restrictions were being implemented responded to staff approaching her about these policies with the following statement. Number one, I am not a visitor. And number two, we are not having this conversation. So against this context, the impetus for this study is personal to us. A few of us on this research team maintain an active clinical nursing practice. So I work as a registered nurse at a residential hospice, in addition to my academic role. And Vasiliki Bitsas, who is one of our co-investigators, is a senior nursing leader responsible for all of palliative care across a wide network of hospitals and community health centers in Montreal. In the blink of an eye, we saw our beloved settings of nursing practice become almost unrecognizable. For example, loud red signs proclaiming no visitors allowed that went against everything we thought we knew about palliative care. The sculpture pictured here, for example, is from the palliative care unit that I worked on for several years. It was created by our art therapist. It is a hand casting of 4 team members physically holding on to one another. It is a powerful symbol of connection that was and remains a core tenet of that unit. So I want to suggest that the main reason that we were so destabilized by the changes that occurred in our care settings at the outset of the pandemic is that we hold relational practice to be an ethical foundation of our palliative care philosophy. And indeed, palliative care has long held that relational practice is core to its identity. And it has always done this from outside of the mainstream. So for example, in response to a wider healthcare culture where treatment is often focused on physiology rather than personhood, where people are frequently recognized by their diagnoses rather than their relationships, and where health law focuses more on individuals than on families and communities. If we look at these 4 tenets of palliative care philosophy that are borrowed from the Newfoundland and Labrador Palliative Care Association, we see that each and every one of them depends on attending and responding to the relational worlds of our patients. So I absolutely love this image for the current moment, because by depicting these tenets as a tree, we are encouraged to consider how deep-rooted these values really are. After all, a tree will often bend in a storm, but it rarely breaks. So over the next hour and beyond, I want to encourage us to think about this pandemic and the associated challenges it brings to our practice as an opportunity to reflect about the strength of our underlying philosophy. What role do we play as nurses or other members of the healthcare team in safeguarding this philosophy when it is challenged? So with these ideas in mind, we set out to speak with nurses who were actively engaged in providing palliative care during the pandemic. We wanted to know how are nurses experiencing and responding to ethical challenges to their palliative care practice. We conducted a series of 17 online interviews with registered nurses, RPNs, and nurse practitioners, working in a variety of contexts: hospice, hospital, community, long-term care. Recruitment for this study is ongoing. So we were joking earlier that we thought we designed the study originally as a 12-week study because we thought the pandemic was going to last 12 weeks. We are still interviewing nurses today, and we will continue to interview nurses until the pandemic is over. In the next slide, I'm going to start to introduce you to some of the nurses we met and the stories we heard. But first, a little caveat. These stories were shared with us at a specific moment in time, so summer 2020. And in many ways, the world has changed a lot since then. And in other ways, things are much the same. But regardless of whether and how specific circumstances continue to change as the pandemic evolves, what we really want to convey is the overall spirit of what we are sharing today. We believe that these messages from these nurses have broad ethical relevance to our understandings of palliative care philosophy and practice, and understandings that matter for how we respond to the pandemic as long as it is with us and even after it is over. So I'm going to take a sip of my water. And I'm going to introduce you to Laura. And all names that I'm going to use are pseudonyms. So prior to the pandemic, Laura had been responsible for coordinating a program that linked palliative care patients in the community with volunteers who would offer visiting and psychosocial support. Her role included following these patients over time, usually with a phone call every few weeks to see how they were doing. But when the pandemic started, Laura was redeployed to inpatient hospice. She therefore found herself managing 2 roles, still trying to follow her patients in the community who at this point had lost access to volunteer support, but realizing that it was taking her longer and longer to follow up with them with the competing demands of her other role. Like all of the nurses we spoke to who provided inpatient or community palliative care, Laura explained the shift that happened across these 2 spaces. So patients and families were so reluctant to leave their home to be admitted to hospital or hospice for end-of-life care because of restrictions on family visiting. And this meant that patients and families would tough it out for longer than they otherwise would in the community, all while contending with decreased access to community-based support. So, so when patients finally would arrive at the hospice, Laura and other hospice nurses we spoke to described a similar profile. Tearful goodbyes at the front door, with patients and families realizing that they would never see one another again. Family caregivers having been pushed beyond their limit, and being extremely exhausted and burnt out, and patients admitted so soon before death with little time remaining to establish trusting relationships and optimize symptom management. At the very end of the interview, we asked Laura if there was anything else she would like to share with us, and she told us this story. So now I'm going to read from Laura's interview. So this is Laura speaking. I had an experience last week that just has been kind of sitting with me. And to be honest, I'm starting to feel a little burnt out. I dread going to work some days. I'll come home and cry more than I did before, especially if a patient has died. Last week, there was a young mom in her 40s who was dying, and she was no longer really conscious. Her partner was at her bedside, and we had the window cracked open because her 2 children were also visiting. A son and daughter in their 20s on the other side of the window. This woman ended up dying while her kids were outside. And just seeing the daughter just crying and wailing and calling for her mom through the window was just so heartbreaking. I think we all understand why these limits are put in place, but we were all just so angry. And I was thinking for myself, if I were that daughter, I would be barging through here to be with my mom. I would not care about the regulation. And then at the same time, I'm the person who's imposing these restrictions on people. So I just feel really torn a lot of the time. Like Laura, Talia straddles 2 roles. She has a part-time role in residential hospice as a frontline RN, and she also works as a palliative pain and symptom management consultant covering a wide geographic area in a rural setting. In that role, she sees her patients wherever they are, in their own homes, in long-term care, or in hospital. Early on in our interview, we asked Talia the question that you see here on the slide. How has the pandemic affected hands-on care, the way you relate to patients and families? And she told us, it's awful. That's probably the most that I bring home with me every day, which is very odd because you'd think you would be more fearful of bringing home what could be a life-threatening virus. But what I'm carrying with me more, and at this stage, she paused, she became emotional, and her voice started to break. What I'm carrying with me more is the inability to have the therapeutic interaction, you know, the personability of it, to hold their hand and have them see your face, sort of wearing that journey with them, as opposed to this big mask and goggles. So after sharing that reflection, Talia proceeded to tell us a story. So again, I will now read, this is Talia speaking. I had this gentleman just the other night who has advanced dementia. When I first introduced myself, I usually go into the room and I take down my mask 6 feet away so they can see my face. And they know who I look like, and I have a button on that has my picture. But for any sort of personal care, you have to be all garbed up. And I went in about an hour later to give him some care, and I had to have all my stuff on. He was sort of half asleep. He woke up, he saw me there, and he was just terrified. Because I guess I would look terrifying to him. And that for me hit home, because it shouldn't be that way. Because when I introduced myself to him an hour earlier, it was jovial, it was welcome, it was a sense of peace. He felt comfort. But in that moment, it really resonated with me how awful it is for these people. Their environment has changed so much. Their loved ones are not around as much as usual. And now you're essentially coming in and you're like this monster who is now expecting to, you know, give a bed bath or a shower. And she finishes by asking, how terrifying would that be? Erin is a nurse practitioner who works as part of a consult team that focuses on providing palliative care in the home, as well as in long-term care, retirement homes, and rural hospitals. When the pandemic began, she shifted many of her patient visits by necessity to in-person video conferencing. We asked her a very broad question about any noteworthy deaths that had occurred since the pandemic began. She told us a story that, in her words, made her question the validity of video conferencing. Her patient was a man in his late 50s with end-stage lung disease who was still working. And what COVID had done was allow him to be working from home and not tell anyone how sick he was. When Erin met him by video conference, she felt quite concerned about his breathing, and so she decided her next visit would be in person. But before she could see him again, he died. I'm now going to read from Erin's interview. And so it was a day and a half after I had seen him and he died. And that was shocking to me. And I keep looking back to say, would I have seen something different if I was in person? With the video conference, I was only speaking to him. But when I'm in the home, I'm speaking to everybody. So his wife would have been there for that conversation. They ended up calling 911. It was such a shock that he had died, but would we have seen something that could have prepared us that maybe this was a possibility? That death has really stuck with me. And I think I've had a much lower threshold for home visits since then. So this story led to a conversation about what is lost when community nursing happens via video conference. Erin explains that it totally transforms the nursing interaction, much of which typically occurs, in her words, quote, at the door. In other words, because most of the patients she sees do not come all the way to the door to let Erin in or out, that is a time for family to give Erin a heads up about what has or has not been talked about, to clarify or elaborate meanings around things the patient may have said, painting a much fuller picture of how the illness trajectory is actually playing out and its impact on the whole family. In Erin's words, over video conference, quote, you don't get those subtle looks where the patient and their family might be sitting next to each other and the patient tells you something and then the daughter discreetly gestures, communicating something else entirely. None of those nonverbal cues are possible in a video conference. The last nurses I will introduce you to are Katherine and Christine. They are both clinical nurse specialists for the same palliative care program in a large urban hospital, providing palliative care support to any hospitalized patient in their institution. I've already told you that nurses commented on the impact that pandemic restrictions had on the movement of patients across community and institutional settings, with people staying home longer than they normally would for fear of entering an institution where they would not be able to be with their family. Katherine and Christine spoke to this very phenomenon, but from their standpoint as hospital nurses. They were seeing less and less patients for palliative care, quite simply because these patients were not coming to hospital. And for those that were already in the hospital, they were desperate to get out. These two nurses told us stories of patients and families discharging themselves against medical advice. These were patients who, from a palliative perspective, were extremely unstable and could expect to experience what they referred to as a horrible death. Patients and families, quite simply, though, didn't care. Their single most important objective was to escape the institution that was keeping them from being together at the end of life. To give you a sense of these nurses' philosophy of practice, I want to first share a story that Christine told that was kind of emblematic of how she practiced palliative care before COVID. So Christine describes going in her role as a CNS to see a patient on a medical unit and finding the patient's husband reaching over the bed rail trying to give his wife a hug. So this is a quote from Christine. She, the patient, was sort of delirious and she just wanted to be held. The husband was reaching over the side of the bed rail trying to give her a hug in bed. So I pop down the railing, I scoot her over, I'm like, you hop in, so they could cuddle in bed together. And the other nurses seemed surprised, but I explained to them, this is the intervention. This is what she needed. She didn't need more medication. She needed her husband to give her a hug. Families and that connection have always been a palliative care intervention, she says. And so I think that's so important that we try and facilitate that as much as we can. It is so important. So throughout their interview, Katherine and Christine told us different stories about working with patients and families to do exactly that, to facilitate family connection as much as possible, even in light of pandemic restrictions. They told stories of advocating at the highest levels of hospital management for dying patients to be able to be surrounded by their loved ones at the end of life, and in supporting families to do some of that advocacy themselves. Part of their motivation to advocate in that way was driven by the uncomfortable feeling that it was simply wrong, that they should be allowed to be so close to their dying patients while loved ones were literally outside in a parking lot. As Katherine said, the term essential visitor is such a weird term. Those loved ones are more essential than I am. And after offering us that reflection, Katherine continued and said, I think that a part of this is how our big healthcare system just doesn't really value that humans are spiritual beings whose relationships nourish that spirit. We are so physically minded, but that piece that we know as palliative clinicians about the holistic nature of a human being, the holistic nature of a human being so important, that piece is just not recognized. And so when you're talking to these people who are making concrete rules from a purely public health background, they just don't understand. So now, having introduced you to some of our participants, their context, and their stories, Kim is going to speak to what we've seen recur across the interviews as a whole. She will elaborate on two of the most significant ethical challenges to relational practice that nurses described, namely in relation to visit restrictions and PPE. And she will also elaborate on the ways that nurses are advocating for the relational needs of their patients and families at the end of life.
Thank you, David. As David has described through some participant stories, palliative and end-of-life spaces transformed virtually overnight. These COVID-19 related changes had sweeping implications for patients, loved ones, and nurses in multiple healthcare settings, which in many ways served to fracture the circle of care. So palliative care philosophy is fundamentally person-centered and holistic, engaging patients and their loved ones in whatever ways best support and foster a good death, as defined by the patient and their loved ones. One crucial way that a good death is actualized is through this circle of care. This metaphor positions the patient and their loved one at the center of this holistic approach. This approach is responsive to physical, psychosocial, and spiritual dimensions of suffering and support patients' experiences of self-determination, control, and dignity. Contributors to the circle of care, first and foremost, include patients and loved ones, and may also include primary and specialist care providers, professional caregivers, such as nurses, additional family caregivers, and a multitude of community resources. And the nurses that we spoke to reported multiple fractures to this circle of care resulting from COVID-19 related policies. The most apparent impact on the circle of care was COVID-19 visitor restrictions. These restrictions separated patients from their loved ones, which serve as the core center of that circle of care. This was problematic in many ways. As we know, the circle of care is dependent upon meaningful involvement of loved ones. This includes their physical presence. Some participants even described loved ones as a palliative intervention, as David described in Christine's story of bringing down the bed rail and having the husband and wife hug each other at the end of life. The context in which restrictions unfolded and were upheld seemed to slightly vary. However, the ethical implications appeared consistent regardless of settings. As one nurse articulated, the change that has impacted me the most emotionally has been the visitor restrictions. I'm finding it very hard. This quote accurately reflects the collective experiences of the nurses we've interviewed so far and sets the stage for the rest of the presentation. When we looked at how nurses described these restrictions, institutions appeared to have varying visitor restriction policies and varying degrees of exceptions to these policies. Restrictions ranged from a mandatory 14-day isolation period on admission with absolutely no visitors, while others allowed one essential visitor. Additionally, nurses also described that some settings specified specific windows of time for visiting hours, with some being as short as 1 hour per visit. Nurses also highlighted that palliative populations were not considered a unique population within these policies. Participants felt largely left out of decision-making regarding pandemic policies. As one participant stated very plainly and poignantly, we have been forgotten, which led to a one-size-fits-all approach to visitor restrictions, which, as another participant eloquently noted, in palliative care, there is never a one-size-fits-all. Nurses also told us that compassionate visiting could be requested. However, the guidelines for that also varied and was most often permitted when death was deemed imminent. The definition of imminent also varied, ranging anywhere from a projected 24 to 72 hours of expected life left. Alternatively, some institutions use the palliative performance scale, with a cutoff of 10 as the determinant for compassionate visiting, which, as many of you know, a PPS score this low is often associated with widespread disease. Patients could potentially be experiencing confusion or delirium. Sometimes these patients are even comatose, which makes meaningful communication with family practically unobtainable. These restrictions possess moral risk for multiple reasons. Multiple participants described how difficult it was for loved ones to make important care decisions when they were unable to visit, especially when families were not physically seeing their loved ones decline. One example depicts a nurse having to FaceTime between a patient and their wife, so the wife could physically see her husband's decline. The patient's wife simply began to cry and asked the nurse if her husband was going to die that night. We also heard heartbreaking stories of patients being separated from loved ones at the time of death, with Laura's story continuing to stand out. Watching family wail for their loved one through a window can never be unseen. These moments change people in profound ways. These stories are troubling, as increasing amounts of research suggest that physical presence of loved ones at the time of death is strongly attributed to a good death. Additionally, family separation at end of life can cause lasting psychological stress and increases the potential for complicated and/or disenfranchised grief. This is something many of the nurses we spoke with also worried about in the context of the pandemic. One nurse, Christine, who David spoke of, described the implications of these separations as suffering on many levels. She stated, patients are suffering because they're isolated, and family members were suffering too. This nurse also stated that she could not believe how much nurses were suffering. She told us that, because it's palliative care, that's when loved ones are supposed to come together. So to have this, what she called a complete mismatch, served as the catalyst for nurse suffering. And I think this quote is an excellent articulation of the multi-layered and complex suffering nurses were attempting to mitigate and really trying to prevent, but also the suffering that they were simultaneously experiencing as they witnessed the implications of these visitor restrictions. So essentially, this one-size-fits-all approach to restrictions superseded an individualized approach to care. And this created moral distress for the nurses we spoke with. As one nurse noted, in palliative, one visitor is not enough. Although participants recognized the importance of public health measures to prevent the transmission of COVID-19 and the seriousness of the virus, they disagreed with the extent to which visitor restrictions and patient isolation should be happening within the context of palliative care. Participants believed that exceptions made on case-by-case bases were both possible and necessary because, in the words of two participants, people are locked away from their families. These restrictions are robbing time. Nurses experienced additional moral distress when they had to enforce visitor restrictions, as doing so created ethical dissonance for these nurses. One nurse recounted having to tell a young father that he would have to choose his wife or his mother to be the sole visitor, in addition to not having his two small children visit at all. For this nurse, she said it was one of her most heartbreaking experiences, and she told us it was harder than telling someone that their family member had died. For some participants, their reflections led them to see hypocrisy in enforcing these restrictive policies. They explained that if the roles were reversed and it was them being kept from their own dying loved ones, they imagined themselves breaking down doors to get in, which was highlighted again by Laura's narrative, the first story told by David. Lastly, nurses did describe their own experiences of compassion fatigue and burnout in light of having to attend to the multiple roles in the absence of loved ones, which again was further compounded by the absence of other formal caregivers, which included allied health and volunteers. And I do want to highlight how significant the loss of volunteers was. This was noted by multiple nurses. Volunteers helped with everything from meal preparation and delivery in some areas to providing comfort and companionship at the bedside of palliative patients. This additional work needed to be absorbed by nurses, which contributed to this feeling that they were the person for these patients. In addition to visitor restrictions, the wearing of COVID-19 related personal protective equipment was a salient theme brought up by every single participant, and its impact on relational practice is important to highlight. The constant wearing of PPE served to alter nurses' abilities to engage in some of their relational work. What was at stake here was physical connection. As noted by one participant, when we asked her what she missed in her practice, in light of the pandemic, she said that physical connection with people, to be able to touch someone's arm and for that not to feel weird. Another participant noted how much touch was missed. She highlighted that she was now unable to even wash a patient's face without gloves. Other participants described how physically challenging it was to display emotion through masks, face shields, and for some of us who wear glasses, fogged up glasses. Recall Talia, who described feeling like a monster, while another participant described feeling like a faceless robot, which of course creates a stark contradictory image to how palliative nurses normally engage with patients and families. Multiple nurses also brought up the impacts of PPE on patients with existing cognitive impairments, most notably patients with dementia. These nurses felt that PPE was exacerbating cognitive impairments, which proved even more challenging as visitor restrictions often prohibited loved ones to be at the bedside to support that patient reorientation. Another element of PPE that altered nurses' relational practice was the pressure to preserve it. For example, one nurse remembers not entering a patient room when she normally would have, and instead she was writing instructions on the glass wall of the patient room for the nurse already in the room to read. Another participant recognized that clustering care solely to preserve PPE meant they were going in the patient's room less, which resulted in less time with patients, which again, when compounded with existing visitor restrictions, meant patients were receiving even less human interaction in the absence of their loved ones. In addition to the physical barriers created by PPE, nurses also stated it was more challenging to adequately get to know patients and their loved ones. For example, a participant in hospice describes patients not being able to bring in personal items anymore, which often served as a starting point for getting to know patients and the lives they led outside of the hospice. These items supported nurses' relational practice. Another nurse explained how much harder it was to get to know loved ones, as communication was much less than nurses were accustomed to and occurred through platforms outside of traditional face-to-face connection. Most often this was via the telephone. All of these examples speak to the importance of authentically connecting with patients and their loved ones and how doing so supports nurses in their efforts to provide a good death. So what does this all mean for nurses? Collectively, these changes to nurses' relational practice contributed to nurses' felt inability to provide a good death. I deliberately say felt inability here, because in the data, we also saw many examples of nurses providing good death amidst the challenges of the pandemic. The relational nature of nurses' work and proximity to patients and families provides meaningful moments for nurses to gain unique insight into patients and families' hopes, fears, goals, and needs. Given that a patient or family's perspective of a good death is highly individualized and changes over time, relational engagement with the family is required to identify and enact care that is consistent with how they envision a good death. Therefore, how nurses respond to these insights are ethically significant as they support a good death from patient and loved ones' perspectives. Nurses struggled with both the physical and metaphorical distance that they were experiencing in their relations with patients and families, and did feel challenged to provide a good death. One nurse, for example, stated that her work and her work environment now felt so cold. Through these and many other examples, it became apparent that not only did nurses believe that good death was at stake, but that COVID-19 visitor restrictions were at odds with the core tenets of palliative care. And this was deeply troubling for the nurses we spoke with. As one nurse told us, this policy is creating something that goes so deeply against what is my understanding and feeling of palliative care. So yes, nurses did experience moral distress as a result of visitor restriction policies that they believed to be unjust. However, in response, participants subtly resisted policies through advocacy and some rule breaking to safeguard palliative care values that were at stake and to ultimately attend to rebuild this circle of care. As one participant reflected, policies separating patients and families in palliative care had prompted levels of advocacy she'd never seen before. This advocacy was motivated by nurses comprehending what was at stake, which was the threat of compromising palliative care delivery and potentially compromising the provision of good death. One nurse described a framework that guides her in her nursing practice, which really speaks to the tenets of palliative care and does highlight what was at stake. So she said, "My framework for approaching my practice is the idea of a good death. And for me, that involves family members. Can't separate the family from palliative care." What was interesting to note, though, when we explored nurses' advocacy efforts was that there were ranging levels of success. Some participants described having excellent relationships with clinical directors in their workplace. In these examples, nurses felt comfortable to approach clinical directors to request exceptions based on unique circumstances, often with success. One participant told us how her advocacy efforts successfully led to her entire palliative care unit being exempt from institutional visitation policies. Unfortunately, other participants were not as successful. One participant described pleading as much as we could for case-by-case decision-making, to no avail. While another participant was told, "This isn't your issue, you need to get back in your lane." This was, as this nurse explained, like hitting your head against a wall and getting nowhere. Amidst variable leadership responses to nurses' advocacy efforts, some participants resorted to breaking visitation rules. This happened when rules were deemed to interfere with whatever was most at stake, given the particulars of that situation. For example, nurses used their judgment when deciding how strictly to enforce requirements that loved ones wear personal protective equipment and stay at least 6 feet away from each other when at the bedside of a dying loved one. Some nurses would turn a blind eye to help families remove these relational barriers between themselves and their loved ones. Doing so gave recognition to families' needs to be present and to support one another in end-of-life situations. Nurses understood that the threat was much greater should there be a specific concern for COVID-19. And of course, in these instances, nurses enforced all policy measures. They also recognized that a broad and standardized approach to visitor restrictions carries its own risk for producing a bad death. These nurses thus engaged in on-the-spot ethical decision-making and reasoning and made their own case-by-case decisions. We heard many examples in the data, and I'm just going to highlight a few. One participant spoke about being in the room with loved ones shortly after a patient had died. These family members started to hug one another, which was a violation of the rule that visitors had to stay 6 feet apart. And she stated, "I would never stop a family member from hugging one another in the case of a death." Others described circumventing visitor restrictions after multiple requests for case-by-case exceptions were denied. For example, Katherine and Christine, the nurses Dave spoke of, were repeatedly advocating to allow a dying woman's children to visit, and they were repeatedly denied by clinical directors. So they decided to get the woman in a wheelchair and take her out for a smoke break where her children happened to be outside, because ethically, those nurses felt it was their responsibility to make sure those children got to see their dying mother. So this ongoing study serves as documentation of nurses' perspectives about the ethics of pandemic-related policies, and we believe their perspectives can truly inform the ways that relational practice imperatives are accounted for and actualized in this ongoing pandemic response. The nursing voice brought forth in the data highlights the tensions that exist between a biomedical infection prevention and control model and the core tenets of palliative care, which is actualized through our relational practice. One of the questions I've been asking myself in light of the data we've collected is about how we talk about and assess risk in the context of this pandemic. Predominantly, the biomedical infection prevention and control model has been used to assess and calculate risk. But I do believe, based on the experiences of the nurses we've interviewed, that there is inherent danger in so narrowly conceptualizing risk. What about the risk associated with the bad death? The risk of feeling unable to construe compassion through multiple layers of PPE? What about the risks of not being able to grieve and bereave the loss of a loved one because funerals aren't happening and spiritual support is much harder to access? You know, nurses' actions in this study speak to their commitments to minimizing these kinds of risk. And it's their work and their stories that make me proud to be a nurse. For the nurses we spoke to, their moral distress and ensuing resistance to visitor policies contribute to an alternative perspective about nursing ethics of COVID-19. This perspective is more relational than biomedical. It centers humanity and it honors an inherent right of patients and families to be together at the end of life. You know, so what does this mean? We are finding that within a transformed pandemic context in which public health concerns seemingly override and eclipse other ethical considerations, nurses working in palliative care have not wavered in their commitment to helping patients and their families achieve their own good deaths and end of life. Their actions truly embody the metaphor of this tree. Their practice is deeply rooted in palliative care philosophy, and when hit by a storm such as this pandemic, the branches shook, but they did not break. Thank you. And this is just our last slide with our email. As we had mentioned, recruitment for this study is ongoing. We're starting our second round of recruitment. So our email is there if you'd like to get in touch with us. Thank you.
Wow, that was fabulous. Thank you very much, David and Kim. Very powerful stories. I'm not sure exactly where to begin. I see that we have a great group of participants with us today, over 70 people, and I'm sure there are some comments and questions from our audience. So I would encourage people to type your comments or questions in the chat box. And I guess maybe I could begin with just a general question, I guess, is I know you've been interviewing nurses over time. And so I guess I'm wondering if you've noticed any shifts in the stories or experiences over time, or just people are getting more tired. I mean, I'm hearing that on the news. People are getting very fatigued, but I suspect it's more nuanced than that based on your findings. And so just wondering if you've noticed any shifts over time.
I think one of the things that we noticed is, so because these were conducted in the summer, already at that time, there had been evolutions taking place, right? So nurses were speaking to kind of their experiences of like March and April, and then we're also speaking to their experiences kind of at that time in the summer. And I think, one of the things, for example, is like, because universally and without prompting, when we would ask, what has changed the most? What is the most significant ethical issue that you face? Consistently and without prompting, the answer was visitor restrictions. Like every palliative care nurse said, it's the separation of patients and families. And then they almost always qualified that with, but it's getting better. And what "but it's getting better" often meant was, at the very beginning, it was complete shutdown, one visitor, if that. Whereas, as time went on, different programs began to develop ways to accommodate more people. So, maybe it's 4 visitors, maybe it's, a higher number of people, but only a certain number of people in the room at any one time. Like there was clearly some flex happening there. So the nurses on the one hand were saying it's getting better, but at the same time, they told stories that reflected the exact same distress. So for example, one participant told us of a story that impacted her greatly, of caring for a woman whose best friend in life, who was like a sister, was basically her 5th person. So from the perspective of the friend, like the woman who was dying was her like one person in the world. But from the perspective of the woman who was dying, she had a spouse, she had children. And so this lifelong friend who was like a sister was on the outside, much in the same way as, the children in the story that Laura told us were. So there were changes, but the core kind of themes of what was at stake didn't really shift. Another thing, when you said people are getting more tired, in the summer, at least where we are, things kind of started to open up. And that created a kind of a certain distress for nurses because things were not opening up in their world, right? So, you know, in March and in April, it was just utter chaos in the healthcare system, but it was utter chaos everywhere. So we were kind of all in this kind of shared new reality, and we were kind of, you know, this refrain, we're all in this together. But in the summer, you know, nurses would drive to work, and on their way to work would pass people on patios and people shopping, and, you know, as though like there wasn't too much happening, changed in the world. And it was like, wow, these people are together on a patio, but I'm about to go into a setting and have to tell somebody that they can't be with their dying loved one. So, and the last thing I'll say is one of our team members just told me this week, you know, she was listening to some of this data with like her January 2021 eyes and ears on, and was saying, you know, I think some of this is still very relevant, but a lot of it is different because we're just even more tired now, and we're just even more burnt out. And so that's one of the things that we're definitely going to focus on as we continue the interviews.
And if I could maybe just speak to that as well quickly, a participant comes to mind. She and a few of them discussed how tired they were, and that, you know, all they were looking forward to was their vacation, which was denied. So they were all pulled back to the front lines, and they weren't getting their vacation. They weren't getting the rest they needed. And predominantly, a lot of these were women, as is the nature of nursing. And so they were dealing with the multitude of complexities in their own homes as well, if they were mothers with their kids at home, schooling. And so we already saw burnout there. So I'm interested to see what it looks like now, like 10 months in.
Mm-hmm. Great, thank you. Lots of comments in the chat box, as I'm sure you can see, appreciating this really excellent presentation. There are a few questions though. There's a comment from Christine. When you mention advocacy and turning a blind eye, the idea is highlighted that on top of everything else, we're fighting against the system we're part of, sometimes fighting against other nurses responsible for enforcing policy. So we're torn in so many directions. Lots of other comments, powerful information. I would totally agree for that. There's a question from Diane. I wonder if the location in Canada might have a difference in the nurse's reflection. And a comment from Milton that is very similar. Does this study consider palliative care in emergency situations? So I guess in terms of location across Canada, but also clinical situations like ER or ICU, nurses who have to disconnect vent care without the presence of a family. I know those are big questions.
So maybe I'll first respond to, I think you said it was Christine, I didn't write that. About the kind of, you know, the turning a blind eye and kind of fighting against the system and potentially pitting nurses against each other. That's such a valid point. Mm-hmm. And, you know, I presented some of this data in a much briefer form to a group. So as part of the Canadian Hospice Palliative Care Nurses Group, which is becoming the Canadian Palliative Care Nursing Association, we've been running monthly town halls, which is just a space for palliative care nurses to come and share stories, stresses, and successes. We've been doing that since the summer. And when I presented some of this data, a nurse who was working in long-term care kind of responded to this idea of, you know, sneaking the patient out for the smoke break, or, you know, in those interviews, we also heard about nurses who are letting families in through back doors of hospitals and up a stairwell and kind of telling them like, okay, like you can be here from midnight to 6, but by 6 you got to be gone, because, you know, that's when the watchful eyes of administration comes back. And, you know, kind of presenting this with a sense of, you know, pride that these nurses are ultimately willing to kind of put themselves at risk to do what they feel firmly is right. But this nurse who works in long-term care kind of responded to that and said, you know, we are working in an environment where, you know, there are signs posted inviting family members to report us if we are putting their loved ones at risk. And so, you know, it's fine to think that like, I'm going to sneak somebody up a back stairwell, but then does that mean that like, you know, somebody else is going to accuse me of kind of, you know, putting somebody at risk, and what would that mean? And so I think that, you know, we are in no way kind of suggesting that like, okay, to hell with regulations, like let's mount a resistance and let's just get all the nurses to, you know, just do whatever they feel is right in the individual moment. The tension between attending to the individual ethics of the person and family in front of you at this time and to the wider collective good is so important. It's a tension that we can't resolve with this study. But I think what is important is to just never lose sight of the fact that even if you can't or won't, you know, break the system, because ultimately your commitment to the collective good from a public health logic is what is right, you know, that's fine. But we should absolutely not normalize this situation. And I think, you know, it's been a year now, like there could be risk in that. And I think, you know, every single time an individual person is not able to be with their loved one at the end of life, that needs to be recognized as a moral tragedy. And if it's not a moral tragedy that has a solution in the here and now, maybe so be it, but at least never losing sight of the fact of how wrong this is will allow us to, I think, hold on to our ethical integrity, which can protect against burnout, etc. And I'm sorry, that was such a rambling answer that I lost the other question.
The other one was in the context of, you know, because Canada is quite large, whether or not geographics played a role. And so we did put our call out Canadian-wide, and we were lucky enough to get participants from 3 provinces, so BC, Alberta, and Ontario, with both quite rural experiences and quite urban. So I'm not sure, and we'll see with this next, you know, set of data, because by now all provinces have in some capacity experienced this, not in the same magnitude, but yeah. And I think the other question was about critical care. So we were lucky enough to recruit a pediatric intensive care nurse to participate. Very similar experiences, very similar ways of circumventing, especially because some of the examples she gave were children very much so at the end of life, and using some of those ways around to have both parents. So in some instances, both parents at the bedside. And what motivated this particular story was that the father was sleeping in a truck in the parking lot. And the nurses, and they were trading off. So the 2 parents were trading off, and the father, when he was not at the bedside, was sleeping in this vehicle. And I think in that context, we need to be mindful that there are only so many intensive care units in provinces. And so people that are not lucky enough to live in big centers have to live somewhere, right? So a lot of those support networks that normally would be in place. So for example, from a pediatric perspective, our Ronald McDonald houses, our Rotary houses, those weren't available for families to stay at because they were closed, because they did have a high risk for COVID-19 transmission because it's communal living.
Mm-hmm. Yes, thank you for that. Clara, did you have a question or comment?
I did. I just wanted to say thank you for so clearly stating, you know, what's happening for our hospice palliative care nurses. Every point you touched on, we experienced that here at our hospice. So thank you for that validation. And I'm just so proud of nurses everywhere. This ties in with Tina's question. Do you see any long-term implications for hospice palliative care nursing in terms of, you know, COVID impact? Tina had said, thank you so much for a powerful presentation. My question, we talk about new normal during this COVID challenge. What is the new normal to your team in palliative care professionally and personally? And that again goes with, you know, what is the long-term implications? And do you have any idea from your research?
So I would say two things, and they're very different. The first thing, which I think is the more obvious answer, is the grief and the I think we could even go so far as to say the PTSD and the trauma that our healthcare workers are going to long after everybody is vaccinated. Really is going to force a reckoning. And so I think that's something that we definitely need to be thinking about. And I think that that is true for everybody who's been involved in the pandemic response, including hospice palliative care nurses. As Kim said, you know, our palliative care nurses have seen things that cannot be unseen. So that's the kind of the more obvious answer, I think. The less obvious answer is, I think that tenets of a philosophy are only as strong as the extent to which they withstand being tested. And what's so interesting about this context is that the issues that are emerging as the most salient issues, yes, are salient in the context of the pandemic, but they're also relevant outside of the pandemic. In palliative care, we've kind of long held that, like, you know, no visitation policies. It's, you know, you will live here as though you are at home. This is your space. Your family is welcome. But wider healthcare culture doesn't operate that way. This idea of visit restrictions was with us long before the pandemic began and will be with us long after. So too tensions in virtual care. And I'm not here to cast aspersions on the validity of telehealth, but there is a push in our neoliberal healthcare system that is obsessed with efficiency that, you know, oh, well, look at how everybody was able to give virtual care during the pandemic. Maybe we should just continue and moving to virtual care after the pandemic. And so the ways in which palliative care nurses have so clearly demonstrated the ethical shortcomings in relation to visit restrictions and in relation to virtual care and other things can have a long-standing implication, which will help us to provide better healthcare outside of a pandemic context, I think.
Thank you.
And I think maybe just to add quickly to that is that what these nurses that we've spoken to have done collectively, when we look at what they've said, is they've created an excellent counter narrative to these taken for granted assumptions that have sort of grounded the way we think of a pandemic and the pandemic response from a healthcare perspective. And it's an important narrative that goes much beyond, you know, just this pandemic.
We could talk about this much longer, and I see there's many more comments and questions in the chat box that we're not going to be able to get to today because our time is up. But I would encourage those who we didn't get to your comments or questions to contact David and Kim directly through the email address that you see on your screen, nursing@uottawa.ca. I'm sure they'd be delighted to have a conversation with you. I do want to, on behalf of Clara and myself and all the people who joined us today, thank you so much for such a moving and insightful and informative presentation that actually is missing from the media that I hear today, which is so medically focused. We are really not totally understanding the depth of the effect of this pandemic. So I do want to thank you so much for joining us today and sharing this research with you. And we look forward to future updates as this goes on. And hopefully it doesn't go on that much longer. But as you suggest, we have much to learn from it for the future. And so we look forward to that as well. So thank you so much. And we hope to see you again soon. And thanks to all the people who joined us today and for their participation. We hope you'll join us again. And thank you to Clara as well for hosting this with us, as well as the Canadian Association of Psychosocial Oncology. So I want to say bye for now.
Thank you so much.
Thank you.
Thank you.
Bye.